So it's good to acknowledge that pediatric setting is vast and
Yeah.
wide. So depending on what you're looking for, what you're assessing, and the type of setting, you'd have different tools. And the main basis of using those tools is enshrined in the frame of reference that you use. It's actually interesting when we used to learn about frames of reference in first year,
Mhm.
would always think about, would you even ever use these things? But
Yeah.
it's actually one of the fundamental areas that will guide you in terms of what direction you're going, what assessment tools you'll be using. So uh, I'll actually start with when I was working with the learning disability services, where we are looking at the child's abilities in a school environment and things like that. I would typically use the Berry VMI. So which is VMI standing for Visual Motor Integration.
Yeah.
Um, and basically it's a tool with three sub tests. One focuses on hand-eye coordination. The second one focuses on visual motor um, skills, and the last one focuses on looking at the child's motor coordination aspect. So our goal would be looking at the child's challenges. Are they having challenges because of motor coordination issue, which is impacting their handwriting? So almost like loosely translated into a child having challenges putting their thoughts onto paper. So like the Berry VMI helps us a lot in that. We also use, let's say like for sensory processing, it's a lot of questionnaires that we give to people that spend the most time with the children. So we have caregiver sensory profiles, school sensory profiles, as well as um, if a child is above a certain age, let's say like 12, they also have a self questionnaire that they also complete. So you would want to see at the behaviors being exhibited in one or more areas. But like I stated, all these would be based upon what frame of reference that you need to use. So even before you pick that assessment tool, you also want to know what is normal or what is typical and what is atypical. So typical development from atypical development is something that's also fundamental. So the good thing that the USET program did was to teach us in those areas, and would do either presentations or the lecturers would work through some of those areas from primitive reflexes to how we develop, even from being a fetus to when you're now crawling, walking,
All those
jumping, and
milestones. Yeah.
exactly like looking at all the milestones and things like that. So it's definitely useful information that you definitely need to use. Even the anatomy and physiology, it's going to be fundamental because it's also going to be helping you to guide if you're using the biomechanical frame of reference, so that you'll be able to know how the body works, the kinesiology of movement and things like that.
Yeah, yeah, yeah. So on these assessments, I appreciate that there are loads of standardized assessments in pediatrics. What of non-standardized assessments? I mean, the observations, I mean, those kinds of assessments. How often do you use them?
So as much as they're regarded as standardized assessments, we need to be very careful and cognizant to whom they were
Yeah,
standardized
yeah,
to.
definitely.
So most of these tools are either standardized to the American population or to the British population. So just because they're standardized to those groups, it doesn't mean even us in Africa, we can't use them. We can use them, but we definitely have to be considerate of different factors. So as well as a trained clinician, one of the most fundamental pieces of an assessment or a good assessment is your clinical judgment. So because a standardized assessment is a standardized assessment, but it will not trump out a good observation by a clinician.
Yeah.
So you would find, let's say if the child is completing the Berry VMI, I'm now observing how are they holding the pencil? How are they seated at the chair? How are they fidgeting? Where are the legs placed? How are they looking at the paper? Is it tilted? So you're looking at everything else, because with occupational therapy, we typically say our main goal is not really looking at the end product, but it's looking at the process in which the activity is being done. A child might score with flying colors on any tool or standardized tool, but if they're using way too much force, way too much energy to complete it, it almost defeats that purpose. So we are looking at all those things that comes with it. So observations are critical. So the best tool is to observe, observe, observe. But even when you're observing, you also need to be factual when you're writing. So initially what I do is when I'm observing a child, I write exactly what I see with no interpretation. And it is later at the end that's when you start looking at what could have been the function of the behavior and things like that. So yes, observation is the greatest tool we can use as therapists.
Wow, wow, that's great. That's great. Can we maybe move on to talk about interventions? I know the setting that you are currently working in, you are purely doing assessment, if I'm right. But I would want to know from you some of the interventions that are used in PEDS.
Intervention. So if if you still remember, we used to write those long case studies.
Yeah.
And I'll actually tell you, it's almost deja vu, because I'm almost writing those long case studies as the report. And why I'm mentioning this is sometimes being able to identify the function or the reason why the child is having those difficulties is actually the beginning of the intervention. I typically tell most parents about when we used to study and be learning about strategies and things like that, we used to focus more on what the adults or people around the child could do to assist the child. We have now since changed. We now want to focus on the child gaining insight into why they're like that, why they're acting like that. So in my setting here, what I do is there are programs that we provide for the child, for the parents, for the schools, as well as we also build on advocacy for the child to advocate for themselves, also equip parents to be able to advocate for the child as well.
Right.
So some interventions we use, especially like, let's say for sensory processing, would be programs such as the ALERT program. The other name is called How Does Your Engine Run? So it's actually meant for the child to know how their engine runs.
Right.
So it helps them with building insight. Some of them would be like the zones of regulation, where the child is learning about what zone they're in terms of their emotions and the state of arousal. But one thing to remember is those courses, you would actually need to be certified or to be able to train on them first for you to be able to implement or to train others to use them. We also recommend several things, from weighted blankets to compression vest and other tools that ear defenders that can be used. Right now, I'm actually going to different schools in the area to teach them or work with them to develop what we call a sensory friendly classroom. So we have been going to schools to work on sensory friendly classroom, because if you go to some of the classrooms, it's lots of posters on the
Yeah,
walls, on the
sensory
chairs.
overload. Yeah.
It's very overwhelming for me as an observer, and I can imagine
What more
how
for the child with sensory processing issues?
exactly. So I went to this one particular class last week,
Yeah.
and I it was after the children had left. So I asked the teacher, we're going to be quiet for 5 seconds, and I want you to listen out to any background noises. So we're quiet for 5 seconds, and I then asked her, what background noises did you hear? So we were able to identify 5 background noises. So this actually included one, the sounds coming from outside, like the cars and people walking past the classroom. The second one was the clock. The clock, like the ticking of the clock, was very loud that you could hear it. The radiator from the heaters, you could also hear the sound coming from the radiators. The other thing was um, they had a radio that the class typically plays throughout the day with calming music. So that was another background noise. And if students were going to be in the class, it's them moving their feet and things like that. So with all these background noises for a child who has auditory processing difficulties, this could be so overwhelming. Oh, actually, there was another one, which is in the class, there's a sink at the back of the classroom, and it actually drips like once every 2 seconds, like the dripping sound. So all those things, they didn't consider them. And after we mentioned, they started looking critically at everything in the class.
Wow. Wow. Prof, I remember you said when you joined this service, it was actually a new service that you were starting. Can you maybe briefly just talk about it so that maybe the audience might be keen to know what sort of setup are you working in?
Yes. So what was happening in Trafford was several kids were going to private OTs to have an assessment for sensory processing,
Wow.
and because if they had what is called an EHCP, which is education healthcare plan, it's like a legal document which is devised for a child who has needs in a classroom,
Additional
and
needs.
anything that is written in it would need to be implemented. So
Right.
it forces the teachers, schools, and other professionals to do what is written in it. So once people were indicated to need, let's say, an OT or sensory assessment, because there wasn't any therapist in Trafford, they would go to the private OTs, and it would be the council that would then pay those private therapies.
Oh, I see. I see.
So the bill was becoming too big for them. So they then wanted to start a service by the council. So that's how this post was created. So the job is when we do the sensory processing assessment, that assessment is also used by the autism pathway, or for the assessment or diagnosis for autism spectrum disorder or social communication disorder, as it is one of the criteria. It's also used by the schools as well as the families who have children with, there's a condition called AFIDS now in the DSM-5. AFIDS stands for um, adverse reaction to food and something.
Oh,
It's
yeah.
children who actually are not eating as much as they should. So they're like picky eaters who eat only 3 foods and stuff. And actually for
Just
this,
when we are there, before I forget, on the picky eaters, I
yeah.
know, Prof, you've actually written a book. Maybe you can just take a second or so to talk about it in case the audience wants to have access to it, then they can actually read what you put in there.
Yeah, so I did scribble something. Uh,
You're very humble, Prof.
so so what actually happened was I actually have two kids, and both of my kids are picky eaters.
Right.
So them being picky eaters, I was thinking about the strategies that we use on a daily basis on top of my own professional knowledge. So we basically took the strategies that we were using at home, and then I was like, let me try and educate others on what we have tried and why children might be picky eaters. Maybe it might help other people. So that's when I scribbled that book. I actually used elephants because elephants, and the elephant is my totem.
Oh, I
And
see.
yes, and on the book, there are actually two small elephants representing my two kids, and then the big elephants representing my wife, when herself and myself are struggling to feed or have our children to eat what we are eating on a daily basis.
Mhm.
So that's why the book was there. There have been a few sales of the book. It there have been also like input from other people, and we are trying to now look at how do we also educate our own population in the Zimbabwean context so that we also bring that awareness and attention so that people in Zimbabwe also learns about picky eating. I still remember when I was young, um, no one would tolerate things like that. You'd almost be like forced to eat. Like
Yeah.
your mom or your granny would like hold your nose and try to just shove the food in your mouth
Yeah.
and
Yeah.
things like that.
Okay.
I
So,
saw this, yeah, I saw this joke which someone was indicating like when our mothers or grandparents were feeding us, it was a decision between either suffocating or swallowing the food, you know?
because the nose
So,
is blocked, you,
ex-
you can't do anything
exactly.
else.
So we definitely need to bring that awareness and attention. So there are ideas coming up maybe for us to translate it into Shona and some of the languages
Oh,
in
that's
Zimbabwe.
great. That's great. In case
But
the audience wants to have access to this book, where can they get it and what's the title of the book?
the book is on Amazon, and it's titled "Here Comes the Aeroplane," because at that time that was one of the main strategies that would make my son eat. Would be like, here comes the aeroplane, and he would open up his mouth. So it's called Here Comes the Aeroplane, a guide for parents. So it can be found on Amazon. And if some individuals, let's say the user or the students would like the book, sometimes I actually make it available so that it's for free to the
Oh,
community.
mhm.
So we can arrange where I can actually put that in so that it's available for that. It's both on Kindle version as well as the paperback, which is the hard copy.
Wow, wow. Thank you so much, Prof, for making that offer. That's really great. That's really great. Okay, so, I mean, for the sake of time, let's look at what else we can discuss. um, in general, what are those things that you consider to be the good things about working in PEDS? What are the positives about working in PEDS? And what could be the negatives, if any? I know you're passionate about this area, so you might not find any negative, but if they are to be there, what could there be?
I think the positive is being able to see the child that you are treating and seeing them develop over the years. like I've seen children who are now adults, and when I saw them, they were just babies. So seeing those changes and transformations, it's uplifting, and it also gives you purpose for what you do, and it validates what we do as as well as like when I worked with mental health. um, you also see changes from someone who has been suicidal, contemplating to kill themselves, and
Mhm.
having set a date when they want to do it, to
Mhm.
now someone who is now focused and is having plans that basically validates what we do. The downside to some of those things, I guess, it's just like any job. So when I worked with the CAM services or the mental health services, I have been headbutted by a 5-year-old, and my teeth almost fell. I had to go to the dentist. I have been stabbed by an 18-year-old that she broke the ruler, stabbed me on my chest. And so it can be risky, but the good, it's almost like there's also a good thing that comes after that. Even if the child stabs you, or the child stabbed me, the next day we were discussing, we were talking, we were working on setting goals and things like that. And I actually enjoyed things like that with working with pediatrics, because I'm not sure you can do those things with
An
adults.
adult.
If an
I see what
adult
you're saying.
stabs
Yeah.
you and you have been aggressive towards you, it's going to be hard to re-engage the next day, the next month. But for children, you can have the child can be aggressive and cussing you off in the morning. In the afternoon, the child is like, I'm coming back tomorrow. I enjoyed my day. So
Yeah.
I
Yeah.
definitely enjoyed those things.
Okay. Great. Great. Any maybe words of encouragement for students who might want to work in PEDS, or any tips or advice for students or other OTs who are working in PEDS? You know the Zimbabwean situation. Okay, I will just assume that you have an idea of the Zimbabwean situation. What is it that they could do as OTs in terms of working with PEDS? I mean, we promote across the world, we're promoting occupation-based interventions, occupation-based approaches. I mean, based on your knowledge and your experiences, what sort of words can you share with students and probably other OTs in Zim?
If if anything, I actually remember the words that we were told by Dr. Mlambo Tekla. Um, she she sat with us one day and she was like, all of you are going to be pioneers in this profession. There are areas that have never been navigated
Yeah,
through that you might need to look at. Yes, you might right now decide, I want to be in adult neuro, in pediatrics, but it's so much vast and areas that have never been explored. And that is what I would indicate to say, yes, our situation in Zimbabwe, it is what it is. And some of the things that we're experiencing in Zimbabwe are actually the same things that everyone is struggling with. Even here in the UK, there are people who have never heard of occupational therapy,
yeah,
just like back home. There are people who also do not recognize what OTs do in terms of other professions. So
yeah,
it's almost us ourselves who have to stamp food and indicate and educate everyone around us. And that is what I have been on the trajectory of doing. I'll actually put this example. When I was in Bermuda, I actually initiated a new program for teenagers that had never been done. And actually through that program, we were actually nominated for a worldwide WOW award, where we
Oh,
had to come to the UK for the ceremonies because it was a unique program that had been introduced for young people.
yeah,
So I definitely think it's lots of things that can be done. It, if anything, yesterday I'm talking about the pediatric setting, even the education setting itself, which you also went into, it's rare that when you're in school that people will talk about, I want to be a lecturer. Most times people are talking about, I want to work in peds, I want to work in ortho, I want to work in MSK, you know.
yeah,
So
that's true.
so even the education aspect of it, it actually helps to sustain the profession in a country. Do not feel pressured to identify where you want to go to right now, because for myself, I thought adult neuro was my area, only for me to then cover for someone else and then identify something different.
Yeah,
So
yeah, yeah,
so as long as you know what's the ultimate goal, take your time, learn from others, identify a mentor, and know that you are still a pioneer in the field.
yeah, yeah, yeah. Wow, thank you so much, Prof. That's why we call you Prof. I mean, the wisdom is profound. And I was very impressed the other time when I saw when you were talking about your service in Bermuda. You had a conference presentation on that, isn't it? I saw
Yeah.
some presentation that you did.
Yes, I presented at the World Federation of OT, where I was actually presenting on that community-based teen life skills program.
Mhm, mhm.
And and I also presented at the International Conference for Psychiatrists and Allied Health Professions, which
Wow,
was in Singapore last year.
wow, wow, wow.
So
Great stuff.
so if anything, opportunities are there for everyone, students as well as therapies.
Wow, wow. Thank you so much, Prof. I'm sure our audience will also appreciate you. In case the audience wants to get in touch with Prof, feel free to drop us an email or a WhatsApp for those who are on the groups that are linked to the Motivate OT's platform. And we'll definitely put in touch with Prof, who is always eager and ready to help. Thank you so much, Prof.